First of all, I want to introduce myself. I'm Michel Bourin, the new editor-in-chief of Archive of Depression and Anxiety. I'm professor of psychopharmacology and psychiatrist at Nantes University, France, and as well invited professor in Craiova, Romania. Archive of Depression and Anxiety is an international open access peer-reviewed journal dedicated to the clinical and investigative studies, treatments, new diagnostic techniques, and other topics relating to the prevention, diagnosis, and treatment of depressive mood and anxiety disorder. The journal publishes novel, updated research information dealing with a branch of medicine which deal with disorders related to depressive mood and anxiety disorders. The journal emphasizes a global approach to continuing medical education for physicians and other providers of healthcare with a specific interest in problems relating to the depressive mood and anxiety disorders and their management. The journal publishes all types of articles in the field of depressive mood and anxiety disorders and their management. It's providing a pathway for discovering new methods or mechanisms for chronic disease and other healthcare professionals to find out most recent advances in all the related areas of depressive mood and anxiety disorders and their management. The scope of Archive of Depression and Anxiety include topics ranging but not limiting to major depression, dysthymia, manic depression, cyclothymia, postpartum depression, seasonal affective disorders, existential depression, mood disorder due to a medical condition, medication-induced depression, substance-induced mood disorder, agoraphobia, anxiety due to a general medical condition, general anxiety disorder, obsessive-compulsive disorder, panic disorder, post-stress disorder, post-traumatic stress disorder, social anxiety disorder, specific phobia, depression, depression therapy, bipolar depression, mood swings, disruptive mood dysregulation, mood stabilizer, reward circuits, mood disorder, and dental anxiety, separation anxiety, and peri-operative anxiety, hospital anxiety, and so on. I want to give an example about bipolar disorder. That is an introduction, if you want, my editorial. Bipolar disorder, which is also known as manic depressive psychosis, bipolar disorder type 1, is a disease that causes mood disorders manifested in both depression and excitation phase. This phase appears either in reaction to stress or for no apparent reason, and may be of varying intensity and interest with period of stability. It is a category of mood disorder defined by abnormal fluctuation of mood, oscillation between periods and elevated mood or irritability. Period of depression and period of normal mood, what is called, generally speaking, euthymia. It happens to everybody to live periods of happiness, sadness, excitement, to be confronted with certain difficulties. However, in the case of bipolar disorders, these changes are out of proportion. They reach such intensity that the person does not realize that he or she is going beyond the limits of the person. Is so depressed, and she is paralyzed and is haunted by suicidal thoughts. This state brings problems with family, at work, financial problem, sometimes judicial. This disease can lead to hospitalization in many states and in state of intense depression. Bipolar disorder can be expressed differently and not recognized from the outset. Unfortunately, this is most frequent situation. Some epidemiological data illustrate the reality. From 3 to 8 years of evolution before the diagnosis was made correctly and specific treatment was put in place. Intervention are 4 or 5 different doctors. The search of period of exaltation is a good means of establishing the diagnosis, but it is not always obvious to the patient to understand that periods when he felt particularly well are the same origin as the period when he felt ill. Given the frequency of bipolar disorder and the importance of prognostic issue, the search for signs of bipolarity should be systematic in the face of any depressive episode. It should be qualified in order to facilitate the diagnostic procedures. The official classification of the Diagnostic of Statistics Manual of Depression, DSM-5, and the International Classification, ICD-11, distinguish these 3 types of bipolar disorder. Bipolar disorder 1 is characterized by 1 or more manic or mixed episode and depressive disorder or depressive episode of variable intensity. Diagnosis may be made even in absence of depressive disorder. An organic cause, iatrogenic or toxic, does not make it possible to retain the diagnosis. Bipolar type 2, defined by the existence of 1 or more hypomanic episode and 1 or more major depressive episode. Third is cyclothymia, which often begins in adolescence, in presenting with many periods and moderate depression, hypomania from few days or few weeks. Cyclothymic disorder is attenuated form of bipolar disorder. It's clear that biological factors are involved because there are anomalies in the production and transmission of brain chemicals called neurotransmitters, as well as abnormalities, hormonal abnormalities, including cortisol, are also involved in stress. These anomalies are themselves linked to genetic factors which explain the family predisposition. It is therefore the interaction of biological and environmental factors that best explain the occurrence of bipolar disorder. Medication called mood stabilizers are used primarily to regulate mood and prevent relapse. These mood stabilizers, which has been shown to be effective, include lithium salts, anticonvulsants such as valproate, carbamazepine and lamotrigine. Their characteristic of action seems to operate differently. Nowadays, the use of lithium is less common due to the constraints of the drug, needs for blood tests and blood tests to adjust the dose and to monitor lithium levels in blood dose effective, being close to the toxic dose. Psychiatrists tend more and more now to prescribe antipsychotic, which acts as mood stabilizers. This may be olanzapine, aripiprazole or ketapine. These antipsychotics are usually effective more or less in preventing bipolar disorder. Antidepressants have long been prescribed abusively in depressive episode of bipolar passion, often due to the lack of knowledge of the illness that was confused with unipolar depression. Only person after our honeymoon and about 2 years in bipolar passion aggravate the symptomatology and should be prescribed except in the episode of acute and intense depression association with mood stabilizers. Treatment approach should be considered not only euthymia as a goal, but also cognitive and functional improvement of patient with such a complex disorder. This introduction to the topic of mood disorder is a way to produce research concerning the frequency of the illness, the treatments, the quality of life of patient, psychoeducation, and a lot of consent. And we thank all the editorial board that you will send nice papers about the topic. Thank you very much.